Testing 1, 2, 3, 4. All right. Assalamualaikum and selamat sejahtera. I would like to welcome everybody to the symposium number 9. And for symposium number 9, the theme is epidemiological innovations in the silent epidemic, transforming non-communicable diseases, surveillance and modeling and prevention in ASEAN countries. We have 5 symposia speakers. The first speaker is Associate Prof. Dr. Mary Ng. Can you hear us, Professor Mary?
Yes, I can hear.
Brilliant. We can hear you as well. So, Associate Prof. Dr. Mary Ng. I forgot to introduce myself. I am Kamarul Imran Musa, Professor in Epidemiology and Statistics from the School of Medical Sciences, but you can call me Kim, K-I-M. So the first speaker is Associate Prof. Dr. Mary Ng, and she's the Associate Professor at the U Lu Ling School of Medicine, National University of Singapore. Dr. Mary Ng is an Associate Professor and Affiliate Associate Professor at the Institute for Health Metrics and Evaluation, University of Washington. Her research focuses on the global burden of disease and quantitative program evaluations. Mary has extensive experience in health data analytics in both academia and industry. A statistician by training, she began her global health research journey at IHME as a postgraduate fellow and later as an assistant professor. She subsequently transitioned to the industry where she led data science teams in tech and in consulting sectors to develop predictive analytics for forecasting health service utilizations, outcomes, and costs using real-world data. Mary is passionate about finding creative solutions to data issues and translating complex mathematics into actionable insight that inform healthy policy and decision-making. Dr. Mary Ng will talk on ASEAN Burden of Disease, a systematic analysis for the Global Burden of Disease Study 2021. Mary, if you are ready, you can share your slide and you can start your presentation.
Okay, let me do that.
The floor is yours, Mary.
Okay, can you see my screen? Oh, is my screen visible? Just checking. No.
Yes, we can see your screen, your slide.
Okay, then I'll start from here. So thank you very much for having me today. So I'm going to share our result on the ASEAN burden of disease. So the agenda for my presentation, I'll start with giving some background of the global burden of disease study, and then I'll follow by sharing the motivation for conducting an ASEAN burden of disease study. And then I'll go through some of the result findings from our work and also conclude by sharing some of the opportunity and challenges that we face. The global burden of disease, in case some of you may not be familiar, it is one of the largest and most detailed epidemiological study globally, which aim to quantify mortality, disability across country, time, age, and sex. So there are 4 main questions that the global burden of disease, which often also known as GBD, try to quantify, which include how many people died, what do they die from, what makes people sick, and what are the causes of death and sickness. So the GBD, global burden disease, quantify a total of 459 health outcomes across 204 countries from 1990 to present. And we have over 12,000 collaborators around the world. And global burden of disease is not something new. It actually has a pretty long history that started in the early 1990s, started as a commission report by the World Bank and WHO. And the report or the study has evolved over time. And in recent days, it has been repositioned or like placed in the Institute for Health Metrics and Evaluation, where GBD now is a home. And in recent years, there will be annual updates that is regularly published in the Lancet. So before I get into some of the results, it will be useful to share one of the signature metrics that some of you may be familiar already, which is the disability adjusted life year. And so in subsequent slides, you will hear me mentioning this DALY or disability adjusted life year. So just briefly, disability adjusted life year, which is DALY, is a metric that often used in all GBD study to quantify disease burden that is resulted from early death, premature mortality, as well as disability. So DALY is made up of two metrics, which is YLL, years of life lost, and years lived with disability. So essentially the concept here is that every single human has the right to live to full health up to certain years of age. And so as you were born, throughout your journey of life, you may encounter injury or some illness that will discount your health. So in this graphic illustration, you see like the x-axis here is life year age. So you imagine someone at as a person at different age, and they encounter different ailment, and then the percent of full health due to that particular ailment. And so YLL, which is years of life lost, refer to the years that was lost due to premature death. And then YLD is referring to the years that is lost due to imperfect health, less than full health. So this is one of the key concepts in the global burden of disease, and you may hear it in my subsequent presentation. And so earlier this year, we have published a series of papers in the Lancet Public Health focusing on a few critical diseases in the ASEAN countries. The motivation for looking into ASEAN burden disease is that ASEAN's population is actually pretty big. It's like ASEAN population is 8% of the total global world population, and few people know that it is 1.5 times larger than the European Union's. However, even though we have such a huge population and we have a growing economy, currently there is not a lot of systematic and very comprehensive epidemiological data, which limit our ability to see the big picture for effective policy planning. So as part of the effort to increase awareness and also make GBD data more accessible to this region, we have launched a paper series in the Lancet Public Health. And this also coincides with the ASEAN Post-2015 Health Development Agenda conclusion, which wrap up this year. And as the region are looking forward to the next post-2025 goal, we hope that this series of paper can serve as a basis for some of the policy planning. And so now getting into the more interesting part, which is the results, some of the findings that we have shared in our publication. So maybe I'll start off with like a general overview of the ASEAN epidemiological landscape. So what you're seeing from this chart, it is what we call a square pie chart. So it is showing the distribution of different types of disease in ASEAN. So the blue boxes here refers to non-communicable diseases. The red boxes here refers to communicable disease, maternal, neonatal, nutritional, and infectious disease. And then the green boxes here refers to injuries. So across ASEAN as a region, we see that 64.4% of the total DALYs, that is like premature death or disability, were caused by non-communicable diseases. So like the blue part is certainly the largest out of all the possible cause of illness. And then 23.8% is caused by communicable disease, maternal, neonatal, nutritional diseases. And then 8.1% is caused by injury. So this provides a general landscape of the disease, the epidemiological pattern of this region. Now, in addition to looking at the big picture, we also look between times. So what you're looking at here is the changes of disease burden by specific cause over the last 30 years, looking at 1990 compared to 2021. So back in the 1990s, the top causes of disease burden in ASEAN is respiratory disease and tuberculosis, enteric infection, maternal and neonatal, cardiovascular disease ranked fourth, and then other infectious disease. So back in the 1990s, most of the top disease burden resulted from infectious disease and maternal neonatal. And then fast forward 30 years, what we are seeing is that the ranking change. Cardiovascular disease now become the #1 causes of disease burden. Respiratory disease has dropped slightly, but then do take note that because this is 2021, a lot of the respiratory infection is also triggered by the COVID pandemic. And then subsequently, in the third place, we have neoplasm, which is cancer. And in fourth place, we have diabetes and chronic kidney disease. And then the fifth place, we have musculoskeletal disorders. So as you can see, the landscape of epidemiology has changed quite a bit in the last 30 years. And I want to highlight a few things here. For example, mental disorder has climbed 5 positions to become the 6th leading cause of DALYs, disability adjusted life here. Meanwhile, we are seeing some reduction in injury, which is marked as green here, but then it's still considered as one of the top 20 causes of disease burden in this region. So for the Lancet Public Health paper series, we focus on these 3 causes of disease burden. In addition, we also look at one risk factor, which is smoking. And so I'm going to start with smoking, and then I'll come back to discussing cardiovascular disease, mental disorder, and also injuries. So smoking is a big risk factor in the ASEAN region. So even though age standardized prevalence has reduced, the absolute number of smokers actually have increased in the last 30 years. So what you're seeing here is the trends in the number of male smokers and also smoking prevalence in ASEAN. So the orange axis here and also the orange line is showing the age standardized prevalence of smoking among males in ASEAN. Whilst the blue bar here is showing the number of smokers, male smokers, over time from 1980 to 2021. So the number of smokers have actually increased by 63% since 1990. And in 2021, there were an estimated 137 million current smokers in ASEAN, among which 125 million were males. So you can see the intensity and the extent of smoking as a regional risk factor. And so here's a picture of how the prevalence compare between males and females and also across the 10 ASEAN countries. So on the left-hand panel here, you have the prevalence across the 10 ASEAN countries for males. And then on the right-hand side here, what you're seeing is the prevalence among females. A very obvious contrast is that female smoking prevalence is generally lower, which is quite common in many countries. And so in general, female smoking prevalence is consistently below 10%. However, smoking prevalence among males in 2021 is still very severe, with, for example, in Indonesia, where there are close to 60% of the male smokers. And Laos and Vietnam also have relatively high smoking prevalence among males. And in the global burden of disease, we also estimate how many of the disease burden, specific cause, can be attributable to a specific risk factor. So we conduct analysis to determine, for example, how many deaths can be attributable as a result of smoking. So what we found is that smoking was attributable to over 526,000 1,000 deaths in ASEAN, and it's mainly due to ischemic heart disease. So what you're looking at on the right-hand graph here is the different causes that is related to smoking, with the ischemic heart disease, stroke, COPD, lung cancer, and tuberculosis. So you can see that majority of the deaths related to smoking was associated with ischemic heart disease. And a different color here is corresponding to the country. And so this is quite proportional, essentially, to the number of smokers in each of the country, with Indonesia taking up most of the number of deaths. And so following ischemic heart disease, we see stroke as the second most common deaths resulted from smoking, and also COPD come third. And in between these two graphs, you see males, the height of the bar is much higher for males than for female, indicating that much of these disease burden and smoking attribute death are experienced by males. So in addition to smoking and the paper series, we look at cardiovascular diseases. One of the most striking findings as we are looking through cardiovascular diseases across ASEAN is the substantial disparity across country. So what you're seeing here on the left-hand side is the age-standardized prevalence of cardiovascular disease for both males and females in 2021. So what you're looking at here, the top three prevalence rate is Malaysia, which has a prevalence rate of cardiovascular disease of 7,200 per 100,000, followed by Indonesia of 6,000 per 100,000, and Laos also very close to 6,000 per 100,000. This is the prevalence rate. The lowest is observed in Singapore, which is roughly like 4,500 per 100,000. But you'll probably still say that, oh, the difference is not that dramatic. The most dramatic one is actually coming from the mortality rate. The age-standardized mortality rate of cardiovascular disease, with the highest in Laos, which is 410 per 100,000, followed by Indonesia, which is 409 per 100,000, and Myanmar with 363 per 100,000. The lowest is in Singapore of 75 per 100,000. So as you can see here, the contrast between the highest and the lowest is almost like 4.5 times different. So if someone is like having cardiovascular disease in Laos or Indonesia and Myanmar, the chances that they survive will be much lower compared to that in Singapore, with a much higher mortality rate. So here shows like the overall picture over time in terms of how prevalence, mortality, and DALYs change in the last 30 years. So on the left-hand panel here is the age-standardized prevalence. Middle one is the mortality rate, and then the right-hand side is DALY. And then the x-axis here is the year from 1990 to 2021, and then this is the rate. The number on the y-axis is rate. Now, the line here is showing either the region or the specific country. So you can see ASEAN here, and this is for Brunei, Cambodia, Indonesia, Laos, Malaysia, Myanmar, Philippines, Singapore, Thailand, and Vietnam. So each of the color line is corresponding to the region or the country. The gray line is representing the global average. So when we are looking at prevalence rate, almost all the ASEAN countries' prevalence rate is consistently below the gray line, which means that the prevalence rate of cardiovascular disease is lower than the global average in ASEAN. However, when we look at mortality rate and also DALYs, what we see is the color line is consistently above the gray line in many of the countries, which means that in many countries, for example, in Cambodia, Indonesia, Laos, Myanmar, Philippines, and Vietnam, the mortality rate of cardiovascular disease is considerably higher than the global average. Now, as I have shared earlier with the smoking, for each of the causes, we also look at what are the risk factors that contribute to that specific cause. For example, in this case, cardiovascular diseases. What are the major risk factors that contribute to cardiovascular diseases in this region? So we see that it starts from the highest of the high blood pressure being the top causes of cardiovascular disease in this region, followed by dietary risk. So dietary risks include, for example, high sodium intake, low low fiber, low fruit, low whole grain. And then the third most important risk factor in this region is air pollution. For example, particulate matter, and then tobacco use comes fourth, and then we have high LDL cholesterol as the fifth most critical cardiovascular disease risk factor. Now, having said that, one of the risk factors that is changing the most rapidly is actually high BMI. So what we are observing is that the DALYs are basically the burden associated with cardiovascular disease that is related because of BMI has increased by 65% since 1990. So this is indicating the increased burden of overweight and obesity and how it is affecting the cardiovascular disease trend in this region. So even though for other risk factors, for example, smoking or even like high blood pressure, we do see a gradual decline, but much of those progress is offset by the increase in obesity. Now, following cardiovascular disease, I want to also give a brief overview of findings from a mental disorder paper. So what we found in our analysis is that in ASEAN in 2021, there are estimated 80.4 million prevalence cases of mental disorder. This represents an increase of 70% compared to the total cases in 1990. And so mental disorder is also among the top 10 causes of disease burden in all ASEAN countries. So on the right-hand side here, what you're seeing is the changes in the ranking of how important mental disorder is among all the different causes of disease burden, how the ranking has changed. So for example, in Myanmar, in 1990, it was ranked to 15th most important disease. But then by 2021, it has moved up 4 position to become the 11th top causes of disease burden. So essentially, as you can see, the white dot, which represents the ranking in 1990, has all shifted to the black dot in terms of moving up in their ranking. So the relative importance of mental disorder, when we consider the big schema of things, is becoming more and more critical as a public health issue. So here is like a representation, a figure representing the differences in the age standardized prevalence and also age standardized DALY. Because for mental disorder, we do not have a very substantial mortality burden. Most of the burden comes from disability. So showing or discussing the DALY rate is more relevant for mental disorder. So what you're seeing here is that there are some variation across the prevalence, ranging from around 10 or 11% in prevalence to close to 13% across the region. So the variation isn't too huge based on our estimation. And then here you see the variation in the DALYs, also showcasing some of the region. The relative burden of DALY is still relatively low in some region, which is the blue ones. And then for some region, it is trending more red, which is indicating a higher burden of mental disorder in these countries. And when we look across the age group, so what you're looking at here is the age, which is represented by the y-axis here, and then this is the number of DALYs. So essentially, you can think of this is an age pyramid showing which age group are experiencing more of the disease burden across the whole lifespan. And each of these colors are representing the mental disorder that we measure. For example, it includes attention deficit hyperactivity disorder, which is typically more prevalent in the younger age group. And then in here, in the red and the orange and also dark red, you see anxiety disorder, which is in the middle part here, depressive disorder, and schizophrenia. So in general, you will see that female tend to have slightly higher mental disorder burden. And then also mental disorder burden also tend to affect beginning from around the age of 10 to 14, it gradually climb up as as age increase all the way to young adulthood, and then it go back down. And the anxiety and depressive disorder, which is represented by the dark red and the red here, is the most common causes of mental disorder burden. And finally, the last set of paper, we look into the injury burden in the ASEAN region. So what you're looking at here is like a heat map of the ranking of how important each of the injury causes is across the ASEAN region. So on the x-axis here, you see the 10 ASEAN countries, and the number here representing the ranking of like how critical, how much disease burden, how much daily it contribute to. So as you can see here, road injury is the #1 cause of injury disease burden in almost all ASEAN countries except 2. So road injury remain a very common cause of disease burden, injury disease burden in this region. In Singapore, for example, there's a slight deviation. Falls is actually the most critical or with the highest disease burden among all the injury causes. This is partly due to an aging population. So as we see a growing aging population, we also anticipate more falls. And there are a few countries such as the Philippines and Laos where we are also seeing interpersonal violence as one of the highest disease burden causes. And again, like looking across age group, this is very similar to the graph that I just showed, where you see the age pyramid understanding, which allows us to understand at what age group and what gender group are we seeing more of the injury burden. So on the left-hand side here is male and the right-hand side is female. As you see, injury tend to disproportionately affect males, and then typically around the age of 15 to 24. This is where the disease burden is the highest. And they tend to be a variety of reasons. There's a lot of road injury, obviously. Another thing to note is that for younger children, we see a lot of the gray area. The gray area is referring to drowning. So drowning is particularly permanent in some countries for young children. And so the graphs here shows the heterogeneity across country. Now this stacked bar chart is showing the relative proportion of the different injury causes across the 10 ASEAN countries. So what you're seeing here again is like the blue here is showing road injury. So it's pretty consistent across many of the ASEAN countries. Road injury is the #1 cause of burden. However, we are also seeing, like for example, in Laos and also in Myanmar and also in Vietnam, we're seeing quite a lot of drowning as well. As mentioned earlier, drowning tend to affect children. So even though there are heterogeneity, what we are also observing is that there are some shared challenges that deserve regional attention, and some regional knowledge exchange can potentially benefit and help improve the disease burden related to the specific cause. And so conclude, I think what we have demonstrated here is that there are huge amount of similarity, although there are differences, and then there could be a lot of opportunity for regional collaboration, which include like addressing micro-level social, economic, environmental, even commercial determinants of health. And then also there's certainly a need to a need to strengthen health information system. A lot of our estimation are based on fairly sparse data, which is not ideal, but then we do believe that it is necessary to produce the best information available to guide evidence-based decision making. And lastly, I think through this process, we also acknowledge that there's a need to develop human capital in terms of equipping the next generation clinician, researchers, and policymakers, in terms of appreciating evidence and utilizing these evidence to improve policymaking and practice. So that concludes my presentation, and happy to address any questions, or like feel free to email me if you have any comment and questions.
Right. Yeah, that's a brilliant presentation, Mary. Unfortunately, I think Dr. Harvey Joy has got something through, right? So I think I'm sure there are questions. If you can, stay with us, maybe let the audience ask you after Dr. Harvey present his presentation after this. Is that all right, Mary?
Yes, that's okay.
Brilliant, brilliant. So thanks, Mary, for the wonderful presentations. On behalf of the conference, I would like to say thank you. But if you can stay back, so that we can ask you questions. And I think we are ready for the next presenter. With us, Dr. Harvy Joy Liwanag. He is the Senior Research Fellow at Assoc School of Public Health, National University of Singapore. Dr. Harvey is a global health system specialist whose research interrogates questions relevant to strengthening health systems in low and middle income countries. At national and local level, he has studied issues of health governance and health workforce development. His publications on the opportunities and limitations of decentralizing the health system in the Philippines have been cited as a reference for understanding the impact of decentralizations in other low and medium income countries. As a strong believer in the role of research in addressing public health challenges, he collaborates closely with government agencies, academic institutions, and civil society organizations in Asia, such as in the Philippines, Malaysia, Nepal, and Indonesia. He has worked with the government or Ministry of Health in the Philippines to develop the country's national health workforce master plan for 2020-2040 and to initiate the Philippine Network for Health Policy and System Research in 2024. At the global level, he interrogates questions about the need to transform global health in ways that have advanced conceptual clarity and improved practice. For example, his analysis of accountability and reflexibility in global health have been used in discussion to promote equity and shift power in the global health system. Harvey, if you are ready, and we can see your slide. So if you are ready, then the floor is yours.
Terima kasih, Professor Kim. Can you hear me?
Yes, we can hear you.
Again, terima kasih for that very kind and generous introduction, Professor Kim. Maybe I'd like to start to say that I was once in USM, in the campus in Penang, sometime in 2019. I think the university then hosted the FERCAP conference. FERCAP is the Forum for Ethical Review Committees in the Asia Pacific. So I have good memories of your campus. And since I'm speaking to a Malaysian audience, I would also like to say that Malaysia is special to me because I lived in Kuala Lumpur for a couple of years during COVID, from 2020 to 2022, when I was working at the United Nations University in KL. So thank you very much for having me. It's a pleasure for me to be joining you for this symposium. Also a pleasure to follow my colleague from the National University of Singapore, Dr. Marina, who was instrumental also in having me for this panel. So my presentation is gonna go beyond the theme of the session, which is really focused on epidemiological innovations. So rather, I will talk about my work and background in health systems analysis. And for this presentation, focus on a couple of building blocks in health systems, namely governance and human resources for health. And I think many of the participants of this conference are health professionals or work in the medical sector. I myself am a doctor, and for us who are trained in the medical profession, we know very well the science behind treating sick individuals, right? A patient comes in with a chief complaint, we diagnose the disease, and then we prescribe the treatment, and the patient gets better. It's a bit more complex when we think about sick health systems, because it is not as if that when you're dealing with a struggling health system, that you can easily intervene and provide a solution which is a silver bullet and everything will be okay. So it's a bit more complex than that, and which is why whenever we deal with health system strengthening, we have to think of the complexity of the system, and there are some frameworks currently in use that can guide action in health system strengthening. Some of you probably, or many of you probably, are familiar with the World Health Organization 6 building blocks framework for health systems. And the idea here is that when we think of a health system, we can think of it as something that's comprised of 6 building blocks, which are not isolated from one another, but are rather highly linked. For instance, there's a building block about service delivery, the health services that are delivered to the population. We can talk about the health workforce. We can talk about information systems, which the previous speaker also highlighted. Think about medical products, vaccines, and technology, financing. A lot of this has to do with social health insurance, for instance, and the 6th building block of leadership and governance. But given the limitation in my time, let me perhaps concentrate on 2 building blocks for this presentation, namely the health workforce and the building block of governance. We all know that health systems cannot function without health workers, right? And a lot of that has to do with making sure that we have enough health workers who can deliver the services required by the health system, but at the same time making sure that our health workers are well compensated, highly competent, protected from abuse, and motivated for the functions that they're delivering for the health system. In Southeast Asia, the question of health workforce sufficiency is very important. And this is something that's probably shared across many of the middle income countries in the region. So from our perspective in the Philippines, for example, we do have a shortage of health workers. Indonesia also has a problem with shortages. Even there in Malaysia, I saw this news article about the lack of doctors. The question probably is then, from a health systems perspective, how do we plan better for the health workforce? And allow me then to share the process we did in the Philippines when we developed the National Master Plan for Health Workforce. And this is in close collaboration with the Ministry of Health of the Philippines. And in developing the master plan, we were basically guided by 3 key questions to inform our policy development. Number 1 has to do with quantity. How do we actually know the adequate number of health workforce that we will require as a country in a way that will meet the current and future population demand for health services, particularly for primary care, since we all know that primary care is the cornerstone of health systems. Secondly, has to do with skill mix. What is the appropriate mix of cadres for the health workforce? Obviously, it cannot just be that we're planning for medical doctors or only for nurses. So we have to think of the appropriate mix that will be required to meet the needs of the population. And thirdly, the distribution. How can we figure out the optimal distribution of the health workforce in a way that will be equitable across the country and could reach the most underserved areas? For example, we know very well that a huge concentration of our health workers are usually in the urban cities, and we have fewer health workers available in many of our rural areas. So if you are the government, if you're the Ministry of Health, how do we plan for our health workforce needs? Actually, if you think about it, one approach is to do nothing, right? You just leave it to market force. Let the market determine the number of health workforce. That is still an option. But at the same time, I think if any Ministry of Health is serious about strengthening the health system, that sort of approach where you don't do planning at all would be unacceptable. So if the goal then is to plan, currently there are a number of approaches available that can guide planning. And in this table that I'm showing from the upper part, these are the more crude, or you would say more simple approach. For example, I think many of us here are familiar with the workforce to population ratios, wherein World Health Organization makes a recommendation for a threshold for density. For example, number of doctors desired for 10,000 population, and then based on that density, you make projections about the need for health workers. A step further than that is to use service utilization or service target approaches, where you analyze the current levels of health service utilization, and then you make a projection about future targets in service delivery. If you want to go beyond that and make it more sophisticated, you can then adopt a health needs approach where you integrate social, demographic, and epidemiological data, which then guides the computation of the quantity of health workers you will need to address the epidemiological burden. And this, I think, aligns very well with Dr. Marie's presentation about the burden of disease. In recent years, WHO also has advocated for what is called the workload indicators of staffing need, otherwise known as WISN or WISN. In this methodology, you go to a health facility and then you make observations about the workload pressure in that specific facility, looking at the actual time that the health workers consume in delivering the suite of services. So this is a rather sophisticated, and it will give you a lot of information. But the problem is that the more you go to the more complex and more accurate methodologies, the more time consuming it would be. So for a Ministry of Health with limited resources, and we don't have all the time in the world to do WISN for all of our health facilities across the Philippines, we had to sort of make a decision on selecting at least a couple of approaches that can guide the development of our master plan. So one of the things that we did is to go with the simplest, which is the ratios. And so that's one approach we did here. We know it's simplistic and it doesn't always give us the answer. But for example, what does the World Health Organization recommend in terms of a target density? According to WHO, in order to achieve universal health care, the suggested target density for skilled health workers should be 44.5 per 10,000 population. And when we say skilled health workers, that's a combination of the total number of physicians or medical doctors, nurses, and midwives. When we plotted the data that we have through the years, and if you put it here, you will see that the ratio for the Philippines is actually 67.9 per 10,000, combining the three skilled health workers. So in a way, this was rather surprising to us then, because if this is correct, then the Philippines has no problem with shortage, isn't it? Because we're in fact above the 44.5, we're well beyond the 44.5. So again, this shows us why the ratios are not really the best way to analyze and identify the gap in the supply of health workers. Now, when we tried to do it in such a way that we looked at the local level, for example, to the left, we separated the ratios for physicians, for nurses, and for midwives. And the graphs at the left, these are the numbers for Metro Manila, which is our capital. And the numbers, the graphs on the right, this refer to the numbers in one of our rural island region in the Philippines. It's called Mimaropa, which is an island region in our archipelago. So if we just look at Metro Manila, all of the ratios for physicians, nurses, and midwives are above the threshold, suggesting that clearly there is a excess of health workers in Metro Manila. But if then you look at a region like Mimaropa, the ratio for physicians is below the desired density. Same with the nurses. The only thing that's above the density is the ratio for midwives. This is a graph showing the number of physicians. So I'm only concentrating now on medical doctors and our projected numbers for the years to come. Obviously, as we go far beyond, the estimates are quite are no longer as accurate. If you go as far as 2050. But again, specifically for physicians, target density is 14.3 per 10,000. And currently, the last time we did it in 2020, the ratio for Philippines was 7.7. So it's clearly below 14.3. But if we're going to aim to address that, how many additional physicians will the Philippines require in order to meet 14.3? That will suggest that for this year, 2025 alone, we should have produced 65,803 physicians just to meet 14.3, which is clearly impossible, because how can you produce 65,000 doctors in 1 year when you were only having 84,000 in total in 2020? So that's not possible. So I'm telling you the process of how we did it, so that when we were looking at the ratio-based approach, and we thought, okay, this is informative, but not really enough to guide our plans. This is then when we included a health needs approach. And again, I'm glad that the first presentation talked about burden of disease, because this time we included estimates about population growth at national and provincial levels. Thankfully, the Ministry of Health in the Philippines has the local data about burden of disease. So we also looked at that both at national and local levels, and also included data related to the level of education in the different provinces, as well as the income of the different local governments. And in the plan, we came up with a calculator that considered the top diseases in the Philippines, guided by the burden of disease data. And some of these were comprehensively discussed by Marie in her presentation. And then we made estimates about the number of health workers we will require. So for instance, if we have the list of priority diseases and we had to estimate the number of hours it will require for a doctor or for a nurse or for a midwife to deliver that outpatient visit at the primary care level. So how many health workers then will be required based on those numbers? So if you visit our publication, we have the calculator actually provided there as an online supplementary material. And it gave us very useful information to guide policy, because using that approach then at the national level, for instance, we have clear numbers about the required number of physicians, nurses, midwives. And in this case, we were actually looking at 10 health professionals. So radiologic technologists, dentists, physical therapists, occupational therapists, nutritionists, medical technologists, and pharmacists. And these are the numbers, and then we will compare them with the numbers that we actually have, and now we have a better information of the actual gap, and then that will then inform the policies that can help address those gaps. And I'm only showing you the numbers for the Philippines, but we also had estimates at different levels, at provincial level and at local level. So this was done, in fact, in the middle of the COVID-19 pandemic back in 2020. And I think you can Google it. No? If you Google National Human Resources for Health Master Plan for the Philippines, you're going to find the plan. And in that plan, we outlined some of our policy recommendations to address the gap. They include training. Our projections identified some of the priority categories that require further support, such as physicians, midwives, dentists, and occupational therapists, because we noted that these were the numbers that were declining in recent years. And since the Philippines, for example, has more nurses and midwives than doctors, we were also recommending stepladder programs where nurses and midwives could then transition to become physicians. And second has to do with central support. So again, going back to that question about inequity, where Metro Manila has more health workers than some of the provinces. So what we've been doing in the Philippines is that the Ministry of Health at the central level will hire some of these health workers and then deploy them to some of the provinces to support the provinces that need them. And also thirdly, task shifting. Since we have more nurses and midwives and physicians, I think we need to start a conversation about some of the functions that could be delegated or shifted from physicians to nurses, so that they'll be able to do them. But at the same time, we need to develop the regulatory framework, and usually this will require a law, so that the nurses and midwives will be allowed to assume those functions. Very recently, I was pleased to learn that this work actually was featured in a recent report by World Health Organization. If you can also Google this, and you can find it. No, the WHO recently published a rapid review of health and care workforce planning tools. And if you look in that report, you will find an example from the Philippines. And it was actually the work that we did. Okay, that's the healthcare workforce. I realize that my time is running fast. I'm going to try to make it faster this time. The second building block that I would like to discuss, this is a bit more political rather than health related. It has to do with health systems governance. And we all know, I'm sure you will agree with me, that in order to address the burden of disease and to strengthen health systems, right, governance is very important. We need good leadership. And we need policymakers and decision makers who are able to make good decisions for the health system. In many countries, including in several countries in ASEAN, probably not in Malaysia, but in Philippines, Indonesia, Vietnam, recently in Thailand, one of the strategies to improve governance is to decentralize, what is called decentralization. The idea here is that, especially for a big country, the central authority or the national government will transfer some of the responsibilities related to the health service to local authorities. And there is good reason to believe why such a strategy might work in strengthening health systems, right? For instance, you can reduce the level of bureaucracy. Rather than, for example, Penang, rather than Penang waiting for Kuala Lumpur or, Putrajaya to make a decision, right? Penang can make the decision. We also assume that with decentralization, local decision makers know better the situation and they're able to better match the services required for local needs. And then you want to empower local governments also, and you want to increase innovation and creativity in service delivery by allowing local governments to be creative in addressing the local health system challenges and not wait for the central government to tell them what to do. And again, this is another issue that's quite common in a number of countries in the region. In the Philippines, we're decentralized, and for some stakeholders, they think it's ineffective. In Indonesia, it's decentralized, but at the same time, the question is how do you balance decentralized with decentralized? And as I said, Vietnam very recently embarked on a major decentralization process. But what is the evidence about decentralization and how it strengthens health systems? Well, if you look at the literature, in fact, there was a Cochrane review that tried to do it, and they are, in fact, authors based in Malaysia. I think in IMU, International Medical University in KL, and they tried to assess the evidence between decentralizing health services versus centralizing health services. But unfortunately, because they couldn't find rigorous studies, including RCTs, for their inclusion criteria for this review, it became an empty review with no findings. Another review looked at the impact of decentralization and equity. There was another review that looked at the impact of decentralization in many low and middle income countries. Quarterly, which is a good journal in health economics and health policy, looked at the relationship between decentralization and improving health system performance in LMICs. Well, except for the Cochrane review, which never finished, if you look at the three other articles, they all give us mixed results. They never gave us convincing evidence on whether or not decentralization actually strengthens health systems. And we think that's really because of a few important issues to raise. And this is a reaction we didn't, one of our reactions to those articles. And we raised the question, I think, first of all, we had to be clear about the type of decentralization that we're talking about if we're comparing different types of decentralization across countries. We also have to recognize that in practice, rigorous studies may not be feasible in assessing the effectiveness of decentralization. It's very difficult, for example, to implement a randomized controlled trial of decentralization in a country that implements decentralization, because decentralization cannot be an experiment. It's often part of the political process that the country undertakes. And thirdly, well, effectiveness is always contextual. So we always have to look at context. And one way to approach the question of decentralization then is to understand the idea of decision space, which was Thomas Bozert of Harvard developed. And the idea here is that when we think of decentralization, we can look at the different functions that localities perform at the local level in relation to the health system. So when we speak of decentralization, we have to be clear about what function is it that's being decentralized. And there is a way to assess the range of choice that local governments have, from narrow to moderate or wide. For instance, when we did that for the Philippines, we had to identify the different decision-making functions that the provinces have to make in decentralization. Are they able, for example, letter A, are they able to plan on their own, or do they need assistance from the central government? Letter B, do they have their own budget, or do they have to wait for assistance from the central government, etc., etc., and then make an assessment about whether decision space is narrow, moderate, or wide. And ideally, in an ideal decentralization process, those decision spaces should be wide, so that local governments are able to make decisions with a lot of flexibility. And in one paper we asked different policymakers and health officers in the Philippines, who do you think should decide for local health service? And I think the challenge is, in practice, if you look at the blue lines on the spider chart, in practice, it's the politician that's making the decision for almost all of the functions except data management and monitoring, letter F. But if you ask them who should have the most influence over decision making, many of the respondents would say, well, rather than the politician, it should actually be the health officer who should be making decisions about planning, health financing, resource management, and other functions. I'm about to wrap up, but in relation to the question of decentralization, then one of our theoretical frameworks being proposed is that in order for decentralized countries to strengthen their health systems, there are three elements that have to work in synergy. One is that they have decision space, meaning it's decentralized, but in practice, they can actually make the decisions themselves for the different functions. Second, they have capacity. That is, if they're going to make the decisions, then we have to make sure that they have the capacity to make the decisions. And that's both at the individual and organizational level. And thirdly, there has to be strong accountability. In other words, when they make decisions, they should be held to account for the decisions they make. And if it's a good decision, they get incentives. If it's an incorrect decision, they get penalized. Think of it like doing skiing. So this was my picture when I did ski in Switzerland before I had my accident. And when I give you a ski, for those of you who have tried skiing, when I give you a ski, the ski only allows you to try to ski, but it doesn't make you an expert skier, right? The ski is like your decision space. But the second element is that you should know how to ski. You should have good capacity. So maybe you should enroll in a ski class and learn how to ski. And thirdly, you have to be accountable so that you follow the rules and then you don't hit other people when you go down the slope. So that's our framework for decentralization in order to strengthen health systems in the context of decentralization. So in ending, this is my summary slide. I think this is a presentation that's focused on analyzing health systems. I think we all agree that health systems are complex. There are no easy answers and we need to think critically. And in the areas of governance and health workforce, there are cross-cutting issues across Southeast Asian countries. And I think it would be great to learn from one another and how we address health workforce shortages and how we address governance. We have to keep in mind that these are only two building blocks, and we haven't even discussed the other building blocks of the health system. And these building blocks cannot be strengthened in isolation from the other building blocks. We need to think and act in terms of systems. And since I've presented a lot of research initiatives, and I think many of you in the audience are also researchers, let us remember that research is not an end in itself, but only a means to guide policy and action. And I will close with a favorite quote from David Sanders, um, previously from the People's Health Movement before he passed away. I think in one article in the Bulletin of the WHO, he made this statement. Most health researchers to date have only studied the world. The point, however, is to change for the better. So I hope that in whatever role we have in the health system, we do research to generate the evidence, but let's also use that evidence to change for the better. So again, terima kasih. In fact, I'm not going to leave yet after 3, so I'm happy to take some questions and participate in the discussion. This is my email address in case you want to keep in touch for further engagement. Terima kasih.
Thank you. Thank you very much, Harvy. I think that's a brilliant presentation. Um, uh, yeah, and hopefully you had great times when you were in Malaysia and USM before. I think we can have a few minutes before we move on to Professor Dr. Muhammad Ayub Sadiq. If you can take maybe 1 or 2 minutes, or if there are questions. If you don't have questions, then I'll ask Prof. Ayub to continue. But let's see if there are questions from the audience. All right, Dr. Marcy, Dr. from Philippines, one questions. I'll bring the mic to you.
Thank you for the opportunity. It's funny having to meet Harvy Liwanag online. I believe he's a Filipino, right? Are you Filipino, Harvy? Yes.
Yes, ma'am. I think marami tayong common friends, I believe.
Yes. Okay. So
Nice to meet
it's
you.
I'm so pleased to meet you and to listen to your talk. You talk about the lack of doctors in the Philippines, and on my end as an educator, um, our concern, I guess, is with schools now in the Philippines either increasing their student population, or state universities setting up more medical schools. Have you made any projection as to whether, with the numbers that we're producing in terms of medical graduates, whether we're any close to the projected need of or addressing the shortage of doctors in the Philippines?
Thank you, Dean Atienza, I believe, from St. Luke's. It's a pleasure to meet you virtually, and hopefully we'll have a chance to meet in person. Yes, we've done projections, and there are two approaches we used. When we look at the ratio, on the question of medical doctors, we will never meet the ratio, as indicated in one of the slides. So it's a bit impossible to meet the target threshold, which is why we said we have to be realistic in our approach and think of a better way to assess the gap. So we went to the second approach, which is the health needs approach. And currently the numbers are there. When I was at DOH, we calculated the numbers. But I think the challenge is we know the gap, but it's really up to our policymakers to implement the plan. And unfortunately, that's beyond me. So our work as a researcher was to work with the ministry to tell them that this is the number. And I think at the moment, we know that it's currently not being met. And it will require, I think, a whole of government, whole of society approach. At the moment, DOH is providing some scholarships for many of our public medical schools, but I think there should also be a way to support the private medical schools so that they can also encourage more enrollment and produce more doctors. But at the same time, we consider the equity. How do we work together so that many of the doctors we're producing can actually serve in many of the areas where they're needed, especially in some of our far-flung and disadvantaged areas. It would be great if, I think it still exists, the DOH currently has a HRH network, Human Resources for Health Network. It's supposed to be a platform for bringing the different stakeholders together for collective action. So I think it would be great if St. Luke's College of Medicine could, if not yet engaging in that platform, could be brought into to be part of the network. And I'm happy to make introductions with the Health Human Resource Development Bureau of the DOH for that to happen.
All right. Thanks, Marcy, and thanks, Harvey. There's one questions from Prof. Dr. Muhammad Ayub Sadiq from University of Brunei Darussalam, and to Mary, Associate Prof. Mary. So I'll pass the mic to Prof. Ayub.
Thank you very much, Dr. Prof. Mary. It's a very insightful presentation. My question to you is, you mentioned about 64.4%, which is about 2/3 of disease burden is from NCD, and let's say the rest are 1/3. So it is 1:2 kind of ratio. But that data is about the whole ASEAN, I believe. So is that pattern is the same in all 10 countries? And another question is very much related to that as well. You also mentioned about the 2025 diseases ranking. I mean, from, if I'm not mistaken, from 1990 to 2021 or something. At the time is a lot of a number of NCD diseases climbed, but again, that pattern is in the whole ASEAN. I'm just wondering what will be individual country. Is it the same pattern or different pattern?
Yeah, thank you for the question. So yes, those numbers are from ASEAN, and then actually individual country data are available on the Global Burden of Disease website, where you can take a look at a specific country ones. But then just to quickly summarize, what we are seeing is that the consistent trend is all the ASEAN countries are moving towards more non-communicable disease. So that's the definite trend. Now, if you compare Singapore, I think Singapore, it will be like 80% will be NCD. Versus in Laos and Myanmar, we still see some portion of like maternal neonatal condition, for example. So there are certainly variation, but then in general, like we are seeing NCD becoming more and more prominent in this region. And the same with the ranking. One interesting thing is that cardiovascular disease is the #1 for all the country almost. So even though there are fluctuation in the subsequent ranking, but then cardiovascular disease is the top causes of death in almost all the countries. If it's not the top, I think Singapore will be second, but then if it's not the top, it will be the second. So CVD, for example, is like a definite one that affect all the countries.
Brilliant. Well, because of the time, Mary and Harvey, thank you for being with us. It is unfortunate that you were not able to join us here. Maybe next time. Thanks again, Mary and Harvey. You can, if you don't have important things to attend to, you can stay with us. I think now we move to the next presenter, Symposium presenter, and next we have Professor Dr. Muhammad Ayub Sadiq, a professor from Institute of Health Sciences, University Brunei Darussalam. Dr. Muhammad Ayub Sadiq is a medical statistician by training with the background of medical doctor, public health, and occupational health. He obtained MBBS from Myanmar in 1985, a Master of Public Health from Mahidol University, Thailand, a Master of Health Sciences, Occupational Health from Edith Cowan University, Perth, and Master of Medical Statistics from the University of Newcastle, Australia. Currently, he is a professor and research lead in Institute of Health Sciences, University Brunei Darussalam. He's also the chair of the University Research Ethics Committee and the head of Teaching and Learning Center of the university. Prof. Ayub will talk on bridging gaps, building skills, a regional collaborative platform for knowledge exchange and training in statistics and epidemiology in ASEAN. Prof. Ayub, the floor is yours.
Yeah, thank you very much. Bismillahirrahmanirrahim. Assalamu alaikum and a very good afternoon, everyone. As mentioned already, the title of my talk, it's about the regional collaboration platform for knowledge exchange and training, statistic epidemiology in ASEAN. Can I get my slide? Okay, so I believe I'm invited for a for the middle one, in conjunction with the ASEAN medical networks. Thank you very much for the invitation and also the title that given to me. It's a okay. It's very much very close to my heart because I do a lot of training. My specialty, I would say, in it's like a medical education, but statistic epidemiology education. So I am going to propose some sort of a platform for the region. So let me start with a little bit very simple idea as an introduction. You know, public health decision. To make public health decision, right decision, we really need the data. Like just now, Prof. Mary mentioned, evidence-based decision making. I want to use the words that she mentioned. And again, to do the evidence-based medicine, statistics and epidemiology is the really key things. And then in ASEAN, okay, whether we have an adequate scale to do this kind of a task or not. That is again a question that I would consider. Another question is if even though we have what you call any collaborative effort for this particular issue to increase the skills and to work for this evidence-based decision making and so on. I just want to quote this: without data, you are just another person, just an opinion. So we really need to work on it. And I'm going to bring you with very simple 3 talking points. The first is just to go through the situation analysis. We want to see the diversity of a health status, especially a manpower situation, because I'm going to talk about a lot of training and things. And then current existing ASEAN collaboration, what currently we are doing. Then after that, finally, I would like to propose a future collaboration platform for improvement. So the first talking point is situation in ASEAN. Okay. In fact, lack of commonly available data, really monitor primary healthcare. It is reported by ASEAN itself. Joint report on the situation analysis of the ASEAN healthcare. Not only that, just now earlier presenter, Prof. Mary also mentioned about we have a lack of a weakness in the health information system. So it is health system, it's all about the data and so on. Yeah. And then I would like to look into the infectious disease. COVID-19 recently happened. More other infectious diseases are also happening. Dengue fever, TB is also re-emerging. And then would like to see the non-communicable diseases. It's on the rise. That previous presenter has mentioned about it. And then environmental health related and also universal health coverage. It's a manpower things. So these are the things that I will look at it about current situation. So this is the first paper that I want to present. It was published in PLOS. These researchers look into health-related SDG. They look into 27 SDG health-related indicators. Altogether, is about 7 themes. You can see there. It's about nutrition, maternal child health, infectious disease, NCD, and also environmental health, and universal health coverage and injury. So very comprehensive, 27 indicators, 7 themes, that what we are interested. And this paper presented, this is a what you call a heat map kind of thing. And that 27 indicator, they come up with scoring 0 to 100. And they see the diversity in the region. Or the greenish one is the highest score, and the lightest green is the lowest score. You can see there, Brunei is a score 90, Singapore is 93.2, Malaysia is 80.56, and so on. You can look at the color, you can see some degree of diversity, of course. And then they look in, this is a more clearer because with the graph, so you can see the trend as well. All are coming up. I mean, they look at this 27 SDG indicator from 1990 up to around 2020. And after that, they have the forecasting for another 10 years as well. So you can see quite diverse. The lowest countries are like around score between 20 and 40, and the highest are around 80. So we are very diverse. Yeah, and then what I want to highlight is, of course, every country are climbing up. And then I just want you to notice the pattern. The yellow color and a little bit light green color. These countries are at the lower, for example, like Myanmar, Cambodia, Laos, and so on. So you will see the same pattern in the next more detail as well. And what they study is that seventh thing. Also, they make a plot. So at that time, you can see infectious disease very much diverse. Yeah, that's the reason as well. I just recently asked Dr. Mary about the infectious disease pattern. How is it like? So the MCH, environmental health, the only relatively not very diverse is non-communicable disease. You can see in the lower plot. And infectious disease also very diverse. And when you come to the rightmost plot, universal health coverage, you can see the data pattern is very strange. In fact, it is showing lack of data because data will not be that kind of things. So accuracy of the data is also quite questionable. Yeah. Another thing is, this is a different report. It is from ASEAN itself, ASEAN database, but you won't see a lot of detail in that database itself. This is a population. You can see that from 2000 to 2023, the population is moving towards aging, right? And then that aging is, you will see more in Singapore and Thailand. Sorry, I cannot show with the, yeah, Singapore and Thailand has the largest older people population. And the rest are more or less similar. The rest countries are not that very different. And in terms of fertility rate as well, again, Singapore and Thailand, they have the lowest one, and the rest are very similar pattern. And infant mortality rate, if you look at it, it's very much diverse. Yeah. And then you can see the same pattern, the high infant mortality rate you see in Laos, Myanmar, a little bit in the Philippines, and so on. The same thing in the under 5 mortality as well. Again, the tallest part are Laos and Myanmar, and then Philippines, and the rest are there. So at least what I want you to observe is diversity. We are not the same in the 10 countries. So we probably will have a different pattern and different problem, different issue, or different priority. Another thing is you can see that from this ASEAN report, the two types of vaccination, DPT and MCV, measles vaccination has a much more problem than DPT. So that's why recently there were a number of measles outbreaks in the region, in some of the countries. Indonesia, the Laos are a bit lower kind of vaccine coverage. And this is about healthcare, what you call manpower density. So you can see there again, the same pattern you might see. Myanmar, Cambodia, Laos, Philippines are relatively lower manpower compared to the rest. And this is another paper very much about the assessment of data availability in the ASEAN region. Here as well, you will see what you call this is overall data availability. You can see a little bit surprisingly the 3 orange area. You see the orange is in fact the lowest data availability. The other countries are, the green is higher data availability. You see the Singapore, and after that Brunei, these relatively rich country in the region, they are very strict with the data sharing. So that's, I know it even myself, but the rest are quite giving away the data. But that is one thing in overall. But when they dissect into more detail, they dissect the data availability in terms of health system input, health system output, and health system outcome. At that time, again, you can see very clearly that his health system output, which is about healthcare accessibility, about coverage of the selected intervention, and then quality assessment. This is the area that people are not sharing or lack of the data. But relatively speaking, the other two are having much more availability. So another thing I want to share is, okay, this is the one that, in fact, just now Dr. Mary Nine reported about it, because I mean, these are very significant and contributing a lot in the literature. So in fact, she mentioned about all 4 project detail, but in that editorial, it mentioned just a very summary things that I just want to report to you. Cardiovascular disease, it's 148.1% increase in the last decade. So this pattern you can see. And tobacco smoking also, even though a lot of activities we do, is still 63.3% increase since 1990. So we still have a lot of things to do it. 10 mental disorders, and again, what you call 80.4 million cases mental disorder currently, yeah. And the most affected age group is 10 to 14, which is very worrisome, because these are the age group that should be very productive, right? And the only positive point is the injury incident rate is declined, but still the absolute number is considered very high. Because of that, we still need to do a lot of intervention. And then this editorial stressing on this 4 paper and informing to they were published in early 2025, but they suggest, recommend the ASEAN meeting, official meeting in June, to consider to emphasize on the health, because that June 2025 ASEAN meeting is like the highest level. All the ministers come together. Most of the time they discuss about economics and politics. So this editorial is trying to remind them, please talk about health as well, because these are the problem. Yeah. But at the end of the day, there are also some other article I found in the literature. I searched in a PubMed. And then you can see here what I want to show you is the quality of epidemiological and statistical scale. And this paper, I won't mention which paper, I will mention from which country, yeah? But you can see already comparing all the country, what they are comparing is number of cases. Is it okay epidemiologically just to compare the number of cases in the country, right? Because if more population, it'll be high. So my point is, the whole paper, I read it, that is not epidemiologically not very right, but it is managed to publish. It's a journal, Epidemiology and Health Journal. And not only that, this is another paper published in even PLOS. But when you look at it, all are again number of cases a million. Yeah, in Cambodia, how many cases? In Indonesia, how many cases? So what I'm trying to address is we are trying to see how much skill we have in these countries, and I mean ASEAN region, so that we can see whether we come up with a sort of a training. Yes. So in overall, I would say another thing that I see is I look into the very recent 50 papers. Only 5 papers published are addressing about infectious diseases. 45 papers are talking about NCD, ASEAN related. Yeah. So just now, Dr. Nai mentioned about the 66% are NCD, disease burden, which is 2/3. So 1/3 is communicable disease, and the rest. That's a question I asked. But when you look at the what researchers are doing, yes, the pattern is very different. 45 out of 50 research papers are about NCD. So I'm a little bit worried about CDR neglected or not. Yeah. Again, it's my question. I'm not saying I have an answer for it. Okay. And then data are scattered. You can see already all the studies are very much investigator interest. It probably may not be what ASEAN need. Okay, investigator, because we all are, it's nothing wrong. What I mean is we all are specialized in one area, and that particular area we will do research, right? So when investigator driven one, so it will be everywhere. It is not a very organized one. So if ASEAN as a body, if we set our interests, and after that we really strategically do research together, it will be our interest. right? That's a thing that I see. The quality of the data and skill also, I can see quite a big question. Study report, again, that's what I mentioned already, very individual or investigator interests. And then very little is about comprehensive or ASEAN interest-driven acquired data or report. So you can see some of the needs from this review, yeah? Now I want to go into the current existing ASEAN collaboration. So you can see already that data problem, or what are we doing currently as together as an ASEAN, okay? And one of the very distinct one is a few distinct or prominent activity that I found. This is a one ASEAN Emerging Leaders Public Health Emergency Management. In fact, this training is a 7-week fellowship, mid-level leadership training. And then first cohort was done in June, July 2024. And they have done a second cohort as well in October. And then they do some degree of online and also offline face-to-face as well, this activity. But what I'm trying to say is this is coming up by US CDC. They want to fund for it, and they come to our region, and together with the WHO, they do this, okay? Another one is very much epidemiology related. It's a very active group as well. ASEAN +3 means China, Korea, and Japan together, and field epidemiology training. In fact, they just started with a few preparation meeting, what you call a steering committee meeting in somewhere in 2023. And after that, they conducted a few activities. You see, what they did is genomic epidemiology in surveillance and output investigation. It's very much after COVID-19. These are very much coming up, yeah? And then a training workshop for genetic epidemiology, again, it is in 2024. So what they do in 2025, they have a rapid response team project. This is also very much related to what you call a outbreak kind of management, yeah? And it is a 3 days workshop. And then next one, urban epidemiology practice, modern style workshop. Again, another 3 days. And they also have a training of trainer kind of activity. The workshop is about 10 days workshop. And there is also some other training, quite active, climate change related, but it has happened virtually in 2025. And there are also some activities, ASEAN activities together, ASEAN Emergency Response and Treatment Team. And then they talk about information management, which is about the data collection, analysis, and communication effectively for disaster management. And then another group is working on infodemic management, because during COVID time, we have a lot of, we learned a lot about misinformation and disinformation things. So this WHO-led workshop activity happened in 2024 once. And then another group is now start doing a health impact assessment for ASEAN member states. And it's virtually happened in 2025 once. I'm not quite sure as well how they will continue, how many times, and so on. And another one, ASEAN Asian Cancer Prevention Control Training Program. The funding is from China Belt and Road Initiative. It's a 1 month online, after that 1 week face-to-face. It was done in 2017 one time, 2018 one time, 2019 one time, and stopped. So if you look at it, these are the established or prominent regional program, if you look at it, and they are mainly focusing on emergency management, the epidemiology training network is also active, and cancer is also one of the activity that, again, but you see, they are doing mix online and in person, and then they have a very specific target with the funding agency interests. Yeah, thank you. And then very short, intensive, and of course, training in overall university MOOC partnership are also available there. Yeah, and in overall, if you look at it, I would say there is no single unified, strategically designed public health training platform currently we have. Everything is like a bit ad hoc, fragmented, topic specific, donor funded, institution-led initiative, and we're not sure about effectiveness. We're not sure about sustainability. Yeah. So in university as well, we have a training, but all of the university training are also with their national interests. It's not about the ASEAN interests. So what I want to propose in the ASEAN collaborative platform, let's make it strategically designed, need-based, should be feasible and sustainable. So in the center it should be comprehensive and holistically tailored to the needs. And then it should be feasible and sustainable. It should be effective and continuously improve. It should be not only training. After training, we will follow up our graduates for data collection. Then after that, making up available data framework. And after that, individual country can take the action based on the evidence-based decision-making. Yeah. And then we can also include into digital health, because digital health is coming up. And accessibility and equability also we can make sure with all these activity. And it should be partnership with university and all the country ministries and also industries. So this is my proposal. So basically, what I want to propose in terms of blueprint is, of course, governance is still ASEAN. And then we need to design the training curriculum very tailored to our regional needs. And then these are the core modules. I don't want to go detail. Delivery-wise, I would propose online, which is, we call it asynchronous training program. And then after that, of course, they can do practical activity as well based on their relevant Ministry of Health. This is where we need all the collaboration. And that will be very much minimal cost because of we do online and all these things, like Coursera kind of, ASEAN Coursera platform kind of, yeah? And then design-wise, we call it micro-credential. This is the way coming up. I mean, not necessarily that people have to continue study the whole of the program. They can pick and choose of that something that they want. So it is like what you call a building block kind of thing, yeah? So we call it micro-credential nowadays, and we can give a certificate. Even you learn one piece, one modular credit, you get the certificate. In the future, you can accumulate and you can come back with, I complete your program and give me the degree or something, yeah? And then funding, of course, ASEAN funding, we are expecting other people want to fund also fine. And then spending, of course, that learning platform, we need to spend for it. And then trainers should be paid, but from many countries, we can work together on that platform, yeah? And then what you call research will be also, we need to fund for it. And digital innovation also, we need to fund for it. And this will be very much cheaper if we work together. If we do only in one country, it will be expensive. It's like a Grab kind of concept. Grab is only one program. But after one program, you can plug into any countries, right? So that sort of thing, we can work together. And then we can integrate with whatever existing network on the platform. And our platform is not just only training and research, digital things, and so on, yeah? So what I would like to say is, of course, step by step how to do. I don't want to go to detail because time is limited, but we can start with small, after that build up step by step. So when we build up step by step, as I mentioned, all these things, yeah, we can start with pilot training modules and scale up to ASEAN-wide. And then after that, not only the teaching, build the data gathering, we can have a health information system for ASEAN, yeah, and research and then action and develop the digital health, more digital health activity can go in. So every time we can move up step by step, we can add in. Finally, even what they call specialty training, also we can go for it. And one day we might call it ASEAN Regional Center for Public Training and Advancement. We can start with small, but we can dream for something big, yeah? And a little bit my Brunei experience. In Brunei, we already have a fully online Master Public Health since 2018. And recently, we have also offered master digital public health, because digital is a way to go and everything is fully online. So we are very much experienced with fully online things. We don't mind to start up for the ASEAN fully online, but at the same time, all the programs are from each country plugged into this platform. And then, as I said, the trainer will be paid, but the recipients will be the free for the country. Yeah. And then we already have students from many countries because of it is a fully online. People don't have to leave job. They can still do their job. So they don't have to study what you call the same pace. You might be taking only one module at a time. Yeah. So this is a building block kind of micro-credential system. And then we also have in Brunei digital health development. In fact, many countries have it. And then if we pull together, this will be a lot for ASEAN. Yeah. So research will come built in. Yeah. I think I will skip this one a little bit. This is a digital health activity that we have in Brunei. Yeah. So like, as I said, that kind of thing, if you have it already, if you plug in for the other countries, that's a ready-made, right? So we probably have a different digital health in the region, but we can work together. Okay. This is the population NCD screening program, just with a simple application. Okay, so what I want to call for is strategically designed, need-based, feasible, sustainable, collaborative platform for public health. Together, we can do this. Thank you very much.
Thank you very much, Prof. Ayub. I think this is a brilliant suggestion, and I think we can, inform the ASEAN Medical School Network. You can start off with, using the ASEAN Medical School Network platform, and to make sure that your brilliant key features for the blueprints, can materialize as soon as possible. Yes, thank you, Prof. Ayub. And next, we would like to welcome Dr. Maria Isabel, or known also as Marcy and Etienza. She's the Dean at St. Luke's Medical Center, College of Medicine, William H. Quasar Memorials in the Philippines. I hope I pronounced it correctly. Maria Isabel of Marcy M. Etienza, a medical doctor and HBED Master, has public profession, okay, is the Dean and Chief Academic Officer of St. Luke's Medical Center, College of Medicine, William H. Quasar Memorial in the Philippines. She earned her bachelor degree in zoology, right, Marcy? From the University of the Philippines, Diliman, and her Doctor of Medicine from the University of the Philippines College of Medicine. She was the former head of the Institute of Pediatrics and Child Health at St. Luke's Medical Center, Global City. She also holds a Master of Health Profession Education from the University of Philippines, Manila. She's currently completing her PhD in Educational Research and Evaluation at the University of the Philippines, Diliman. She's a practicing pediatric pulmonologist at St. Luke's Medical Center, Quezon City, and Global City. So Marcy will talk on a topic on culture of care, strategies for wellness and resilience in medical education. The floor is yours, Marcy.
Hello. Yeah. Thank you very much for the very kind introduction. And thank you also for the invitation. I believe I'm here also as a member of the ASEAN Medical Schools Network. So thank you very much. Distinguished colleagues, thank you for the opportunity to share how our school is cultivating a culture of care, a strategic, student-centered, student-partnered portfolio for wellness and resilience at St. Luke's. I hope you can make the shift from the very ASEAN discussion, health systems, public health, country-based health. But I think we, as mentioned by Professor Marie earlier, mental health has risen through the ranks of illness from 11th to 6th, and I believe it has pervaded also medical schools. It sets an alarm because these are going to be the future doctors who will be taking care of us and our own countries, and therefore we cannot set it aside as a non-communicable disease that we need to address. So before I show you our work, let me show you the global evidence that makes this urgent for us. The high burden worldwide, as early as 2013, Assoc published a systematic review showing that large multi-institutional studies show that burnout is widespread in medical school, often affecting at least half of learners. I think back in 2013, not many of us paid attention to mental health back then. Now, the impact is great. Rich, in a recent publication in 2024 involving 8 medical schools in the UK, showed that mental health issues had a considerable negative impact on medical students' ability to learn and progress through their degree. Now, what helps? Wasson, in another systematic review in 2016, concluded that limited evidence suggested that some specific learning environment interventions were associated with improved emotional well-being among medical students. However, the overall quality of the evidence was low, primarily because there were not too many studies. But this highlighted the need for high-quality medical education research in relation to mental health. Now, MUMAD in 2022, in a scoping review, showed that a clear theme that emerged was institutionally provided strategies to promote student well-being tend to be more effective when students opt in and participate in the program. Therefore, mandatory content or activities to a medical program without creating adequate space or support may not necessarily be effective. Thus, the overall statement I guess is make wellness a priority, and in a systematic review recently published in 2024 says that it is imperative that academic leaders charged with the responsibility of educating and molding tomorrow's doctors make medical student wellness a priority so tomorrow's physicians can both teach and model health practice. Now, the global data are unequivocal. Wellness in medical education now becomes a quality issue and a leadership imperative. According to this evidence that I've presented, we now decided to look into our own learners, and this is where we got our marching orders. Now, let me show you here our local experience, but just to give you a little context, St. Luke's Medical Center College of Medicine is a private institution with a 5-year curriculum. We have among the schools in the Philippines one of the highest national medical admission test requirement in the country, with more than 2/3 of our student population with Latin honors in their undergraduate degrees. So it's a very competitive application process, and we have a student population of about 750 in the past 3 years. Our physician licensure exam results often range from 93 to 100% from the past 10 years. Now, despite all that success, I think we need to look at the data, our student uptake of guidance counseling. So we have a guidance counselor's office, and you have here our student population for the past 3 years, and you can see that the consults have been ranging from, these are students, not just the consultations. Number of students consulting our guidance counselor was 102 during 22-23, 115, and finally, the past year, 285 students, and that's from 14% to 38% in 24-25. Now, whether this reflects a more mental health, larger mental health problem, or a greater recognition of the value of guidance counseling, or both, we are not sure, but definitely this signals to us that the urgency is palpable. We need to develop a comprehensive wellness and resilience program. Now, for more in-depth consultation, students are referred to an in-house psychiatrist. The consults are much less, but still a significant number, numbering from 16 to 39 students in each academic year. So against this backdrop, we have decided to do a convergent mixed method study to assess student needs and co-create student partner program initiatives for wellness and resilience. So we ran a school-wide quantitative survey and held qualitative focus group discussions in parallel. On the quantitative side, we achieved 568 out of 744 students. That's 76%, a good number across all year levels, giving us confidence in the data that we have for prevalence estimates and trends by cohort. On the qualitative side, we conducted focus group discussions in all the 5-year levels using a semi-structured interview to guide to surface students' perceptions, lived experiences, and concrete recommendations for a wellness and resilience program. Finally, the data were merged to create themes using joint interpretation to triangulate where signals aligned or diverged and use those convergent insights to co-create the portfolio. So here are some of the key results of the quantitative data. So students were asked to self-rate their overall wellness. Results showed that a trajectory that wellness declines steadily from with seniority. So the blue represent excellent and good overall wellness rating, but as you can see, as they progress through the 5 years, although different student populations, the blue fraction was shrinking throughout the 5 years. Ratings become uncommon, good and excellent ratings become uncommon in upper years, and poor and fair wellness rises during internship or the 5th year. Now, there seems to be a time squeeze wherein insufficient time to focus on wellness increased from 18% in year level 1 as represented by the disagree and strongly disagree when asked the question whether they had time to concentrate on their wellness. And as you can see, we have that segment of red and orange on the far right, referring to the year level 5, meaning to say 57%, over 50% of them are saying they don't have time to attend to their own wellness. As to mental health challenges identified across all year levels, burnout is the most common. And there you have it, 75% of them responded burnout, followed by anxiety, 53%, with 23% expressing depression. The most identified obstacle to wellness is lack of time. almost half of them said they didn't have enough time, followed by burnout, which is 10%, and workload 9%. Now, the most identified obstacle to wellness, for wellness resources utilization, the most used resource that we already have, surprisingly, is the quiet or prayer room, which is half of them. To me, this was a surprise because our quiet room is a small prayer room made for students, but the need seems to be overwhelming. Extracurricular mentoring is 45%, sports and games 28%, and guidance counseling, despite the many numbers, just ranked 20%. Now, the qualitative, so this should be qualitative. Sorry, did I lose a slide? Yeah, this one should be qualitative, sorry. I think this is the first slide that slide set, not the corrected one. I'm sorry. So this is the qualitative part, and the focus group discussions revealed barriers to wellness. And some of them are the inflexible schedule, the exam clustering, the workload, and environmental constraints. Because at that time the survey was being done, the school was undergoing renovations. Now, with these barriers identified, we have identified systemic strategies and proposed actions as recommended by the students. So one is to communicate contingencies, particularly with changes in teaching learning activities or shift to online classes for situations such as inclement weather. I believe right now in the Philippines, classes are suspended because of a bad storm. So it happens at certain times of the year. Two would be to have interdepartmental scheduling of exams and teaching learning activities to address overlaps and overload. And idea of asynchronous access to lectures involving students in the planning of the class syllabi also surfaced as proposed actions. These were kind of unthinkable a few years back, but now students want to be involved because they're concerned as to how things are being managed or the syllabi are being managed. So the third one is to designate alternative spaces during the renovations. Although we know that the renovations were temporary, this led to the need for them to increase access to the laboratory for independent study, and clearly showed how students valued student spaces for study, for rest, and for interaction. So still qualitative, we identified two student identified issues. So this is the first one, is the need for adjustment at different phases of their learning. So this was also an eye-opener because they seemed to identify points in their education as transition periods. And among the actions was to enhance orientation from pre-med to year level 1. Although this was already a long time practice, it seems like they were looking for information to make them adjust more to medical school. Also, they were requesting for provide orientation from 1 year level to the next and during the mid-year. I think this signals how, they need some hand holding through the process of education. So this need for Adjustment also led to recommendations such as scheduling feedback sessions and academic advising, introducing clinical shadowing before the actual clinical rotations in the fourth year, enhancing briefing and debriefing sessions even in patient encounters and discussions, and finally validating student progress by celebrating their many milestones across the years. So quantitative, let me make that correction. The second student identified issue is the varying means to distress among the students. So a one-size-fits-all program will probably not work. So to provide actions to this, the recommendations included: 1, to identify student interests, wellness; 2, provide wellness sessions on nutrition, relationship, mindfulness, etc. 3, to promote immersion activities during the summer, and they can be clinical or research related. And 4, to open clinical shadowing in clinical fields of interest to prepare them for what comes after medical school. Now, integrating both lenses of the survey and the focus group discussions led us to the following themes. And these themes helped us prepare a portfolio of program initiatives. So theme 1 is on academic wellness and the learning environment. So we arrived at 2 objectives: to provide staged, phase-specific support at all academic transitions, and 2, to make the learning environment adaptive through better feedback and academic advising and student progress, and to identify student at risk early. I had a chance to talk about this during the last ASEAN Medical Schools Summit. So for theme 2, the second theme, the need for stress, burnout, and self-care infrastructure. So 3 objectives were arrived at. 1 is to reduce academic structural stressors by way of interdepartmental communications and coordination for teaching learning activities. 2, to expand and improve student spaces. And 3, to promote self-care behaviors and help seeking. The third theme is to institutionalize the culture and community of care. So the program initiatives will have 3 objectives. 1, institutionalize milestones and activities that validate student progress and build belonging. 2, to strengthen school-wide community and peer networks. And 3, to improve communication and open dialogue so that when we hold coffee breaks with the dean and administrators in small groups twice a month. So let me close with a conclusion, reflections, and lessons learned. The convergence of global evidence, and I guess what we heard yesterday and today, and our local data makes clear the urgent need to build an integrated, institution-wide wellness and resilience system. And we have 4 major reflections and lessons moving forward. A wellness and resilience portfolio needs to be designed for today's new generation of learners. 1 that is flexible, student-centric, and ascertains that student opt-in. The portfolio should be created with the students. We need to plan with them to tailor initiatives, not only institutionally, but also by cohort, to stage in their education and their particular needs. Wellness needs to be embedded in their academic life as well as campus life in order to successfully institutionalize and build that culture of care. So after this study, faculty and staff also need to be a part of this evolving culture. And finally, we need to evaluate and iterate by tracking the uptake, the outcomes, and refine further. So in closing, building a culture of care is essential to educational excellence and safe compassionate care. With evidence, student partnership, and leadership, we can deliver high-impact tailored wellness and resilience portfolios to help our medical students to be equipped to serve their eventual patients and the healthcare system. So thank you very much for listening. I have here a photo of the deans and key administrators during the 15th ASEAN Medical Summit held early this year in Indonesia. And again, I'd like to extend the invitation. We welcome collaboration to share tools, to compare outcomes, and advance the well-being of our learners together. So please do not hesitate to reach out. Thank you very much.
Thank you very much, Marcy. And we would like to apologize for the slides. So we use the older version of your slides. So well, I'm sorry for that. As it is a brilliant presentations by Dr. Maria Isabel or Marcy M. Intienza from Philippines. And I think that's very interesting. Evidence-based interventions are very important for the medical grads, I'm sure. I would like to remind you that we will have questions. I will allow questions, but after Professor Besra talk, Professor Besra will be our last symposium speaker. And Professor Besra is a professor at the Faculty of Public Health, Universitas Indonesia. So Prof. Besra was born in West Sumatra and earned his Bachelor of Public Health from the Universitas Indonesia, Master of Science in Biostatistics and Epidemiology from University of the Philippines, and Doctor of Public Health from the Universitas Indonesia. He has been a lecturer at the Universitas Indonesia since 1997 and has held several leadership roles, including department chair and quality assurance manager. His research focuses on maternal and child survival, gender and reproductive health, and quality of life. He actively teaches undergraduate to doctoral students in biostatistics, research methodology, and scientific writing. He's proficient in software like SPSS, Stata, and Minitab. He currently also serves on boards of Indonesian Public Health Expert Association, Indonesian Public Health Institution Associations, and Indonesian Accreditation Agency for Higher Education in Health, contributing to public health education and accreditation in Indonesia. Basically, dealing with the title "The Current and Future Transformation of Public Health in Indonesia." The floor is yours, Pak.
Thank you, Professor Kim. Distinguished participant, chairman, speaker, colleagues, ladies and gentlemen. So good afternoon. Thank you for the invitation. It's my great honor to present the current and future of public health transformation in Indonesia. I am Basrai from the Faculty of Public Health, Universitas Indonesia. Please allow me to take you through our historical roots, our current realities, and the future direction of public health in Indonesia. Let's cover 5 key areas. The first, what public health is. Second, the beginnings of public health in Indonesia. Third, the current state of public health in Indonesia. And finally, we will look ahead at the future direction to build a more resilient and sustainable public health system. To begin, let us define public health. Public health is the science and art of preventing diseases, and promoting health. So, applies health and mobilize resources at the scale of society, whether local, national, and international, to create the condition in which can be healthy. The habitual in Indonesia begins in the 17th century when the cultures activities of smoking, marijuana, cholera, and dysentery. In 1851, the province found the secular Java in Batavia, which later evolved into Sumatra and ultimately become the faculty of medicine at Universitas Indonesia in 1950. Next was the era that focused on smallpox vaccination campaigns, the creation of a public health services, and commitment of statistics, the mapping of controlling epidemic. In 1945, now effect emerged. The breakdown of 1941 led from this level multi health center we call puskesmas, pusat kesehatan masyarakat. By 1968, those puskesmas formed a national network delivering services such as health planning, immunization, maternal and child health. The University of Oxford estimates the first in public health at the University of Indonesia in Jakarta. By the 1900s, industrial first papers were created across the country. The University of North Sumatra in Medan, Universitas Assoc in Makassar, South Sulawesi, Universitas Erlangga in Surabaya, East Java, and Universitas Diponegoro in Semarang, Central Java. Since the of 1999, Indonesia has commenced globalization by institution, by foreign, or the government. Now, let's start in equity through universal health coverage, which covers 97.8% equality towards 24 to 170 without million of Indonesian population by 2024. Everyone is included under the National Health Insurance Scheme. This is London. Let's call this. The terms referred today are complex. Today we have term conflicts in the past and of disease. In physics, a constant such as the causes malform and now continue to affect our people. The product analysis are missing simply. If it is one of our population, the impact of our sun and of our 1%. Medical health issues are also emerging with the 1.4% of the population. Perhaps that's our woman is starting still at 21.5%. After reduction of performance level nutrition challenges. Indonesia today developed a blend of communicable and non-communicable disease, national and our technical concern. The Puskesmas remain the backbone of Indonesia primary healthcare as preventive and preventative services at the grassroots level. By 2024, there were 1,100 Puskesmas, equivalent one Puskesmas and 1,000 population, each serving as the first layer of preventive, and curative care. For the last of ASEAN, Puskesmas manage pendekatan such as general practitioner. So, at the same time, education in public health has expanded. Providing professional with interdisciplinary skills, cultural sensitivity, and ethical funding. Most of however, in Indonesia, the highest one is nursing and midwife and pharmacist and general physician. The professional worker very small. The challenge has remained in distribution and capacity, and studying professional reach the communities that need them most. That's why education is vital to meet tomorrow's demand. It has a component to strengthen its public workers, such as epidemiologists, sanitarian, nutritionists, promotion specialists, health administration experts, hospital administration, and occupational expert. These professionals are at the level of community groups and frontier health program nationwide. Education is a strategic issue. Education and qualification by particulars because Indonesia Accreditation Agency for Higher Education in Health. Public health ensure that it meets national and global standard. However, most public health study programs still have a good accreditation status, with only one third having excellent accreditation. This reflects the next stage of transformation. One of development has been the transformation of the curriculum. Since 2019, program have shifted towards the own interdisciplinary effective communication skills, cultural competence, and strategic leadership and system thinking. By 2024, more competences include research risk reduction, our system, public health in pronouncement, and most importantly, mental health. This solution is equipped with the skills and mindset to design integrated solutions and to strengthen the entire health system. Regards gathering of geographic disparities. In and appearing, excuse me. The program of disease, strain, resources. On the class is responding disease pattern and health determinants. All local health system often struggle with limited equipment and medicine. And finally, Indonesia spending that's still below 1% of GDP. Of GDP. These records remind us that transformation must be both urgent and sustained. To enhance this challenge, the Moderator of law has launched a comprehensive transformation agenda. Organization of ASEAN, measures, human papillomavirus, and more, it is covering non impacts congenital disorder, diseases, thalassemia, disease, cancer, and diabetes. And also, practical focus on cardiovascular diseases, cancer, maternal and child health, diabetes, mental health, tuberculosis, and gene infection. Infection is also different plastic city. Medicine like paracetamol and atorvastatin, as well as medical devices such as ventilators and blood pressure system. This agenda strengthens security and health security and reduce dependency on import. Looking at the future, which was infection this man on resilience against pandemic and disaster. That was intervention. The introduction of medical products is fair and most importantly, have literacy to improve citizens. That is the next area of transformation. Performance was excellent in 6 domains. First, the documents must vary perfectly and informed by systematic learning. Second, formatting must ensure that health and disaster management are really formed. The health offers must be sufficient and equally distributed. Third, medicine and technology must be available often and where needed. Fourth, service delivery must ensure continuity and quality in during process. And six, the information system must perform outcome surveillance and data for decision making. Together, that create a system that can withstand future shock. System public health and public health. System public health analyzes data and intervention to improve outcomes. Such include medical surveillance system, insulin, and fitness devices. Using medical access, we can inform the stage of process cycle from identification agenda setting into C formulation, implementation, and evaluation. This person is transformative opportunity for brain-based decision making in Indonesia. Simplify and behavior. Typically, request for citizens. Identity is more than knowledge. It's also motivating skills and empowerment to make informed choices and navigate systems. Based on how people see, we enhance people to sustain their behaviors, engage with services, and contribute actively to our being. Let us define frame for long-term public health sustainability. In person, the national system is both a historical phenomenon and ongoing mission. From the COVID vaccination campaign to the national health insurance, we make remarkable progress. The significant challenge remains. By emphasizing public health institution, national public health innovation, and data safety in the next is keeping for a higher and more equitable future. Thank you very much for your kind attention.
Thank you so much, Prof. Biswal, for the wonderful talk. I'm really amazed actually with tremendous progress actually, Professor, in public, especially for Indonesia. We have seen Indonesia progress really fast, and I think that is really good for the Indonesian people. Congratulations, Shabas, Pak. And we have 8 more minutes, so I think we got ample time for question and answer sessions. I would like to also open the session to participants online. We have this session broadcasted to the ASEAN Medical School Network. So I also welcome questions from the online participants. If anyone has questions, feel free to raise your hand and say your name and ask your questions. Anybody who wants to start? All right. While you are constructing your questions or try to find your questions, I have questions to each one of you. So maybe I start first with Prof. Ayub. I want to ask about the let's see where's my questions. All right. Okay. I want to ask Prof. Ayub, in terms of how do you see the collaboration between academia and service provider? For example, we at universities and the Ministry of Health, we see that universities are conducting trainings, workshop, for example, and Ministry of Health is also doing the same thing. But it appears that there are gaps and sometimes frictions between the two. So how big do you think those gaps and how sensitive the frictions between the two? And do you think that is an issue? And if yes, how can we work together rather than work in silo to achieve a better training for our future public health, for example?
Yes. The first thing that when I proposed the platform, I mentioned the partnership, university, Ministry of Health, and even with the relevant industries. It is really, really from the very beginning, we need to work together. For example, if we design the curriculum itself for the ASEAN region for, let's say, public health training, we really must talk to Ministry of Health people. I mean, I'm from university, that's why I'm saying we really have to talk to Ministry of Health together. On the table, round table, Ministry of people, university people, maybe in the early stage itself or later stage, industry people, our stakeholders need to be there. Not only Ministry of Health, in fact, it is there are several relevant ministries need to involve. For example, when you talk about environmental health, there are a few other ministries as well that involve. So even a curricular design itself, we need to involve them. So once the partnership is there is no question about friction and all these things. We need to solve that problem from day one. Another thing is we need to know together that what we are doing training is, at the end of the day, is for Ministry of Health. So that is the thing that Ministry of Health will be really, really actively involved, because they are the one who should shape what training they want. We need to understand that. So this is where the platform, we work together, and then even ASEAN itself, these are the health ministers are working together as well, right? Other ministries also involved. So this is the way that I would say. Not only that, for example, even when we run the program, as I said, our experience, yes, fully online. Let's say, for example, if one of the student is from Philippines, we have a practicum. They have to do practical projects in their workplace itself. So what they have to do, we have to talk to Ministry of Health in the Philippines to take care or to oversee what the candidate is doing. So when the Ministry of Health is also knowing our program, they will collaborate. They definitely will take care. At the end of the day, the product is for them, right? Not only that, many of the candidates themselves, as I said, our program is micro-credential, which is a lot of currently people working in Ministry of Health, they will be our trainees. So they want to upgrade themselves to study more statistics, to study more epidemiology. Those who are working as a, let's say, a nursing, nurses, background is nurses, but doing in a public health responsibility. At that time, they probably may not have a formal training about epidemiology, statistics, data gathering, research, and so on. So our majority of our participant trainee should come from Ministry of Health as well. This is why you have no way to separate. All must be in one unit. Thank you.
Thank you, Prof. I think synergy is very important, right? So I think by working together, the the higher education institutes as well as the Ministry of Health, I think we can provide a more robust training and more impactful training as well. Thank you, Prof. Ayub. Any question from the floor? Right. We have a mic there. I think, Marcy, I would like to ask you a question. I'm interested. I mean, with your graph where you show the stress and burnout, and it increases with the more seniority of students. I thought that the senior you are, the less stress you will be, right? Because you see that you are going to graduate very, very soon. But it appears that the more senior they are, the more stressful they are. And it is interesting to see, or if you have any idea, what will happen when they go out, or if you have data when they went out or they go out from the medical school to as houseman, for example, whether that that trend is also linear, and because we have the same issues here where our junior doctors, housemen, we call them, face lots of anxiety, stress, to the extent that quite a number of them drop out from the training. So how do you see that? How could you explain that kind of linear increase in the stress and anxiety, and whether that will continue to their housemanship as during their medical practice?
That's a very interesting question. Well, this is a very young study, but our reflection is that our cohort in this study are those students who were online when they began their medical education. So we don't know if that has any impact on how they adapted once we went back to on-site learning. So I think that's one. But two, we also cannot relax and say now that we're back on site or holding hybrid sessions that we'll probably be seeing less mental health issues, because I think even those who took their undergraduate education during the pandemic are now our medical students. They're now in medical education. So I think it might take a few years before we can really say whether it was the pandemic that has led to this. But I think looking at the studies way back, even before the pandemic, I think we already signaled the red flags. I do believe that we have to come to the point of accepting that we have a new generation of learners. The way they think, the way they adapt, the way they process things is very different from how it was years back. So we might need more time to find out the answer to your question, but definitely we cannot stop with just one study.
Yeah, I think that is very, very important. I think the fact that we can't judge them, I think it's very wrong to say to them, this young generation, that they are weak or soft. I think they are just different generations, and I think we have to really acknowledge the pressure that they are facing. I'm not sure whether it directly due to pandemic. I've seen data. One study that we have not published, 50,000 participants from the Asian countries. We have not published that one yet, and we can see the tremendous increase in anxiety, depression, especially among those young people. So I think whether so the pandemic indeed has done some major to this group of people, and we have to acknowledge that first before we can do some wonderful. So thank you, Masi, for your present your response. Question from the floor? Yes, please. That's mic in front of the table. You can say your name and your question, please.
Yes. Assalamualaikum and good evening. Okay, I am Abu Bakar from School of Dental Science, USM. My question I would like to ask about Dr. Darussalam. Okay, regarding the from your slide, I can see you said that the future step the taken in Indonesia, one of it is health information system. Okay, so I would like to ask, what is the strategic plan for Indonesia in employing this health information system, despite the geographical disparities and also low healthcare expenditure in Indonesia? Thank you very much.
Yes, thank you, Mr. Abu Bakar. Yeah, Indonesia, especially Ministry of Health, has grown. We call it for the next future plan for the 2025 to 2029, and then 2030, 2035. There is a strategic plan, not only for the public health concern, but also for the all of the health sector, including funding, medical equipment, laboratories, drugs, and etc. So for the detailed discussion, we can discuss more detail after this session. Thank you.
Thank you. Yes, I'll have like, yes, please say your name and your questions. I think I have to allow this as the last questions. Right. And make sure that the question is short and sweet.
Okay. Thank you. I'm Dr. Omar bin Azmi from student USM. I want to ask regarding health financing. From my knowledge, health financing in Indonesia have reached 98% coverage with 228 million population. Wonderful slide from Dr. Besra. I want to ask, in your slide, you mentioned 0.8% only using GDP of health coverage I've seen in your slide. So with the health financing system with 98% coverage, so it's quite magnificent. How? I mean, how? That's my question.
So the question is, with that very low expenditure, how can Indonesia achieve this very large,
Yeah. Thank you for the question. This is contradictory, right? The coverage is very high, 96% something, but the percentage of GDP is very low, less than 1%, because the payment for the national insurance scheme, it's quite low as compared to the other ASEAN countries, Malaysia or Thailand. So now the hospitals and as they implemented GK, national health coverage, ask government to increase the fund for the payment from the government and also from the people. So that's the solution. But the health system still run, but run slowly. We are trying. Yeah, because why it's effective? Because we use the payment not for the services, but for the we follow the Malaysia pattern for the payment. What we call it the group of disease, not for the services, but for the group.
DRG, you mean?
DRG, yes. Yeah. Thank you.
All right. Yeah, I mean, I can see, from yesterday plenary by Datuk Syed Al-Junaid and what you have presented. Also, Prof. Fazli yesterday. I think Indonesia is doing very well, and I'm not going to be surprised if Indonesia will do much better in terms of progress. Of course, you started very low, but I'm very happy with what you have achieved. I think it's already it's almost 4:40, and I'm very happy with what presenters have shared with us, including Associate Prof. Mary Ng and Dr. Harvy Joy Liwanag from NUS, and also participants online. So again, I would like to say thank you very much to all of you, the speakers, on behalf of the 4th International Conference on Medical and Health Sciences. I would like also to say thank you very much to ASEAN Medical School Network for funding this symposium as well as the partly the conference through the ASEAN Research Collaborative Fund. So maybe we can give a big hand to all the speakers. So with that, I end the session. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Yeah.